chat. I'm Dr. Nina Vinkoff, and I'm going to be moderating tonight's chat with, I believe, 4 other breast imaging radiologists. And for those of you who are tuning in for the first time tonight, we've been doing this every Monday night at 6, and we're tackling all different issues, mainly related to COVID and how that's affected our various breast imaging practices, but also other topics as well. So if you haven't tuned in, please join us. Tonight, we're going to be talking specifically about things that our breast imaging centers have done to promote patient safety at this challenging time. And I'm going to let all of the people who are on our panel tonight introduce themselves, but we're talking to you from all different parts of the country who are probably at all different phases of their recovery. And so it has probably impacted them differently. My name, like I said, is Nina Vinkoff, and I am a radiologist specializing in breast imaging. I'm the chief of breast imaging at Northwell Health, which is a large health system in the New York metropolitan area. I'm talking to you right now from Manhattan. Also within my department, I'm the vice chair for patient experience. So this is a particularly interesting topic for me because it's the place where patient experience and breast imaging overlap, which is always where I like to be. And I guess what I'll do is I will let my other panelists introduce themselves, and we'll go in alphabetical order. So I'll start with Dr. Byers, and we can just go around and everyone can introduce themselves.
Well, thank you so much. Thanks for having me. This is a topic that I also really look forward to discussing with everyone so that they know our breast imaging centers are safe, we're doing everything well, and are really thinking about everything with our patients in mind. I'm a breast imager in suburban St. Louis with Washington University in St. Louis. We have opened up full bore and are going really strong. So I look forward to talking with you guys about that. And we look forward to any questions. If you want to post a question in Facebook or however you're viewing this, we are happy to answer it.
Great. Either one of Dr. Patel's.
I know, Amy or Mitha. I'm Dr. Patel. I'm from Columbus, Ohio. I'm a breast imaging radiologist at Ohio State University. I'm the assistant division chief of the breast imaging section, and I'm the breast imaging fellowship program director as well. And yeah, thanks for having me.
Oh, Amy, you're on mute, I think.
Oh.
We had you there for a second.
Can you hear me now?
Yes.
I don't know. It wasn't on mute on my end, but I clicked it and now I guess you can hear me. All right. Hi, my name's Amy Patel. I'm a breast radiologist in the Kansas City area. So I'm the medical director of the Women's Imaging Center at Liberty Hospital. And then also my practice, we read for multiple rural facilities in Northwest Missouri. So I oversee breast imaging for 6 other rural hospitals in Northwest Missouri, as well as oversee the breast imaging for a more underserved health system in Kansas City. So I look forward to discussing how we've been employing all of these safety measures across various practice types and various patient demographics.
Terrific. Excellent. And I think I just saw Dr. Kunjman get on, and there she is. Perfect timing. Are you able to hear us?
Yeah, can you hear me?
Yes, perfectly. Would you like to introduce yourself?
Sure. Hi, I'm Jean Kunjman. I am one of the Emory staff at Atlanta, and I'm director of the Breast Imaging Center at the Midtown campus. Looking forward for the chat today.
Okay, terrific. So I thought before we talk about where we all are now, it might be good to go back and just look back to mid-March, early April, and talk about what all of you did back then, what you stopped doing, what you kept doing, and how you let your patients know. I'll just start by saying, here in New York, my health system was really the epicenter of the epicenter. I think even to this day, Northwell Health has treated more patients with COVID than any place in the world. And so we actually made the decision the second week of March to let we thought at that point we would go 2 weeks out. So we called 2 weeks worth of our patients and told them we were going to reschedule them for 2 months forward. That later became 2 months worth of patients that were scheduled for we rescheduled 2 months into the future. And then we continued to do diagnostic mammograms throughout, and we also continued to do biopsies throughout And then we opened up back again for screening in mid-May.
Yeah, so here in Atlanta, we did at Emory, we did the same thing. The mid-March, we stopped all the patients for 1 week. And during that week, we ran a list of the patients that we recommended biopsies, all the outstanding recall patients, and also the patients who were scheduled but got canceled. And during that week and a half, we triaged those patients for urgency. And then we created a spreadsheet that allowed us to track each group. And during that time, we did not do any screening, no screening mammograms or screening MRIs. As far as the MRI, the only thing that we did was the extent of disease for newly diagnosed breast cancers. And we called all of those patients and let them know that we are all the screening patients, that we are rescheduling them, and we will give them a call once we resume our normal service. But during that time, we initially started with urgent patients, and then we went down to time-sensitive patients and did their diagnostic mammogram and biopsies.
That seems to be a common theme that I've heard from most places is what we did in our place, and it sounds like what you did, and if anybody else had a different experience, we really took responsibility, not just for telling patients that we thought that they should delay, but also for making the new appointment for them. So we didn't just shut the door. We basically said, like I've said on previous talks, we're going to put this on pause, not on stop, and we're going to give you a new appointment. And I think that was very helpful, and it actually made the ramp back up easier. Is that what most of you all did as well? Yeah.
Agreed. And I think it's reassuring. All of us sound like we're in positions where we're part of a hospital system or university system. We're controlling or running multiple breast centers. But you may not have felt like this, but I felt like this in mid-March. We were the only ones having to figure this out, and it felt very isolating, thinking I'm trying to make a decision for our hospital system, and I don't know what everybody else is doing. I really found SBI, for example, to be a great resource, and going on our discussion boards to say, hey, this is how we're thinking about this. What does it look like to you? To know that I wasn't making the decision in a vacuum.
Yeah, I was a huge consumer of social media during those early days, just trying to make sure that we were on the right track and doing what other people thought was reasonable.
I think it's also good for our patients to hear that we're doing things the same way others are doing it in other parts of the nation. They know that, again, we're consistent in our practice about this.
I felt like, as being in a position of leadership, as you all might have felt, our hospital systems really rely on our input of, what we shouldn't be doing, how we should gradually be reopening. So I agree, Society of Breast Imaging, the Communications and Advocacy Task Force are imperative, particularly with the reopening. So these discussions are so imperative between, our sections and hospital leadership to ensure that we were doing, the right thing for our patients. So just like all of you, we shut down any type of screening, whether it was high-risk patients, just screening mammograms, asymptomatic BI-RADS-3, it was all gone. And so then once we started slowly reopening we started opening in early May. It was in a very gradated fashion. We started a very slow, small percentage and crept up gradually week by week. And of course, we had to allot more time per patient to allow social distancing, to allow additional cleaning. So there were just so many things involved, as all of you know. So the hospital really relied on us for a formidable game plan going forward, not just for closing down, but for the reopening.
Yeah, we had a similar experience shutting down. We also, like Amy said, we stopped doing our BI-RADS-3s, so our 6 follow-ups, because we thought that those patients could be delayed and paused, like Nina said. I like that word, paused. And then we started back up on the 1st of May, and it was supposed to be a slow, gradual workup, but already right now, surge capacity, just trying to get those patients back so they feel comfortable that they're still getting their care.
Are all of you back to doing everything that you were doing before? Are there any services you're not offering right now? And is everybody finding that you're back either at volume or even at more than normal volume right now? Yeah. Well, it's so interesting. I remember talking to my administrator when we were at the height of this in like early April, and her saying, June is going to be terrible. July, where are we going to fit them? And I said, they're not going to be back until September. I was wrong. They all came back, and we're so happy that you came back. I was really concerned. I don't know about the rest of you, but I was really concerned that women were going to do more than pause, that they were going to skip this year entirely and not have their screening mammogram this year. And it has been such a relief to me to see that wasn't the case.
I think what I feel like made a big difference for us, and you all have referenced it, is the connection we made with our patients during the time we were paused, whether it was through phone calls, through reminder letters, whether it was a call the night before your new appointment, just to say, we've got a new policy in place. We want you to feel comfortable around this. Here's what we're going to expect. I feel like the patients really appreciated being asked back. And so we're at least in our institution going to try to continue that feeling of making an even deeper connection with our patients, that they feel like we're doing everything we can to meet their needs as best we can. So in some ways, mine were more anxious to get there than they were in previous years.
Yeah.
I think that's super important. And one of the things, I mean, it really was all hands on deck, similarly to your experience, Meredith, where we sort of created this data registry of sorts where we made sure that we were calling all these patients, getting them back in. But for us, our nurse navigator was really imperative in tracking some of these patients down and making sure they were coming back for their appropriate follow-up, to ensuring that, you know, they weren't delaying their care. So I think those practices and institutions with nurse navigation program, I think in the time of COVID, it's super imperative having a nurse navigator. I've told her, time and time again, like, you have been the lifeline, you've been the foundation right now going through this, because, you know, just having her there and being able to connect with these patients and help us get them back in, it's just been so tremendous. She's been an invaluable asset.
I also think it's interesting as a breast imager, because most of us, I'm sure we don't use the same one, but all of us have some kind of tracking mechanism already in place for knowing about the patients that needed to be rescheduled. Whereas you really came to realize during this process that in other parts of radiology, that kind of tracking needed to be built in some way. And we did build it in our health system. We actually built an entire website just for this purpose, to keep track of all the patients that we were rescheduling. But in breast imaging, most of us already had something built in with navigation, some kind of tracking system that we always use to make sure that none of our patients were falling through the cracks. So in some ways, I think we were better prepared for this kind of an event than other people, you know, in other subspecialties of radiology, or at least from what I could see in our department. All right, I wanted to just kind of break down, what all of you are doing now that we're back up to volume or even at surge volume. And I thought, just to kind of keep it organized, we would try to just talk through it bit by bit, all the way from the time of the appointment and when you're at the door, as you make your way through our breast centers, and how it feels today to be a patient in our centers. So I wanted to start, anybody can start by answering this. What is your patient screening process right now for COVID? Are you doing things like actually testing, antibody checks, doing temperature checks? Are there specific questions that you're asking? And are you seeing patients who might be at risk for currently being infected?
I can start. At Emory, we are asking, when we schedule these patients, we are asking them definitely the questions that we ask, like, do you have the cough? Does any kind of symptoms, COVID symptoms? And we also ask if they had any fevers. And if they did not have anything, we scheduled them. On the day of the arrival from the hospital itself, they're doing a temperature check for all of the patients, and we are also telling them to wear, if they have a mask, to wear, because it is required for all the patients and all the staff members to wear a mask. If not, if they don't have it initially, we gave them the surgical mask to all of those patients. As far as the, we're not doing any antibody testing for the patients. The only COVID testing are done for the patients who are going through surgery. So all our needle lobe patients are getting COVID COVID test beforehand. Otherwise, all our outpatient breast imaging patients are not getting tested. We just ask these questions, and there's a temperature check during the time of when they arrive in the hospital.
That's very similar to what we're doing. Are any of you actually doing testing on patients who are having procedures other than localizations, biopsies? Is anybody taking any special precautions with those patients? We are not. We're treating them like our diagnostic or screening patients. Are any of you doing anything different for any of them? No. Are all of you masking your patients?
Yes.
Yeah.
Universal masking.
Universal masking.
We also, you know, before the patient arrives, we let them know that the experience is going to be a little bit different. And one thing we've definitely changed, we don't have visitors in our centers more, just to decrease the, you know, the number of people that are in the building, because we have to distance, and also just to decrease what's coming inside. So that's something new for our patients, and we want them to know before they come that it's going to look a little bit different this time, that we are do some of the measures that we're going to talk about coming up, but definitely having a visitor is different. A lot of women, you know, are used to coming in with somebody when they get their mammogram or the one exception is it comes in with a new diagnosis of cancer, you know, need support system. So they, when we try to limit that to one visitor.
You know, that's
We're
nice.
we're doing the same. And you know, honestly, I think some of the changes that we've put in during the COVID surge are changes that are going to stay in place even once we are past this, if and when we are past this. Our hospitals put in universal masking, universal screening, and we then repeat the screening when the woman who comes in the hospital first goes through screening. She gets screened again in our waiting room. Similar to what you're saying, we're not doing, not allowing visitors except in the new diagnosis, but we've actually changed. We used to have family members or the person who accompanied them be present for a biopsy if they wanted. We're not doing that any longer. Our nurse navigator has gone to great lengths to organize our space so that if the person has somebody who needs to be there with them, maybe it's a hospital translator, maybe it's a family member who's providing physical support for them, they just physically need that extra person. We've worked out some creative ways to allow that person in the space, but to really limit where they can be and what they can do. And you know, looking back, I think in some ways our practice was maybe a little informal previously in terms of our interactions with the patients and our policies in place. And now this has really given us the chance to become more formal, and I think it's going to stay that way.
Okay, excellent. One other, well, I think I'll skip that. I'm going to go to, what are you doing for your staff right now? So are you doing things like temperature checks for your staff? Does your staff need to be tested? Do they have to answer questions every day, or are they just, is it formal, or is it more self-monitoring that you're doing, you know, for your technologists, for your nurses, for your radiologists?
I can start.
Oh yeah, go.
So for us at Emory, we didn't do temperature checks earlier on when we started back, but started July 1st, all of the staff, all of the faculty staff, everybody is getting checks, and they have a formal, starting July 1st, it's a formal question answer thing that you have to answer each day. It's an app that you put in the phone, so it's a formal thing that you have to do it every single day. Again, till like last week, it was kind of self-monitoring. They just said, like, if you're feeling, you know, anything, just call the COVID, don't come to work. But started July 1st, it's like a formal question answer that you have to fill before you have to show them the answers before, and they are doing it on all the staff.
We've had a formal system in place for probably about a month now, where you have to log in your hospital ID. You know, you have to take your temperature before you come to work, symptom check, and we get a flag. So you get a green, green flag if you're fine to come into work, yellow or red flag, which you'd have to talk to somebody to see whether, do you need a COVID test? And if you need to get a test, to stay at home and not come back until that test is negative. And our hospital system has also enacted extra sick time, so COVID sick time, so that employees don't feel like they're getting penalized by staying at home, which I think is really important too. You don't want anybody to question that.
I think that's a really good point. I think, one of the things in the culture of medicine, or at least when I was in training in medicine, was unless you needed to be hospitalized yourself, you were supposed to come to the hospital. I think one of the good things about COVID is getting rid of that as a culture and saying that people that are taking care of patients shouldn't be sick and they shouldn't feel bad about staying home if they're sick. And there's a few silver linings to this whole situation. One of it is, as Dr. Byers said, maybe making us a little bit more formal in our processes. And the other is, I think, making just some cultural changes that are just good common sense, that for whatever reason, we're not, at least every place I've worked, we're not really part of the culture previously. What about PPE and masks? You all mentioned that you have universal masking. Was that a problem for you in the beginning? Was that one of the reasons? We didn't really talk about why we all stopped doing screening, but did we stop doing screening back in mid-March, early April because we needed PPE, because we needed time to get our safety measures in place, because we just needed to kind of figure out what this new world was going to feel like? I'd be curious to hear what all of your experience was with that.
I think in our hospital system, it's a combination of those, right? We first looked at each other and said, what do we not have to do tomorrow? What patients do not have to come in our facility? Because at that point, we didn't know if they're in more danger coming into our facility, or were we in more danger with them coming in? We didn't know which way it went. Then I think the second was the masking issue. And I'm in the Midwest, as Amy is too, and masking around here has become in some ways a political issue. So it really took a lot of discussion to get the hospital and administrative leadership on the same page about masking. Once we got there, we can make it a policy system wide, and then felt more comfortable with having patients come in. So it's been a variety of things. And one of my friends uses the analogy about figuring out policy around COVID is that we're trying to fix the car while it's running. This is such a dynamic process. We know something today we didn't know yesterday, and we definitely know things 3 months later that we didn't know at the beginning. And how do we augment our policies around that? What I would love to hear too, as people are answering, is what are you doing? And this, I think, is going to just continue to play out over the summer and fall. What are you doing as your employees, your technologists, your nurse navigators who are sustaining potential exposures, if they become symptomatic, if they fall ill, if they test positive, and how are you adjusting your schedule and your staffing around that?
Does anyone want to take that?
That's a hard one. I'm sorry.
No. I mean, I think it is a hard one because you summed it up perfectly. I think, we didn't know how long this was going to go on. And so some of the things that you might be willing to do where in the beginning, it was very easy to say to everyone, stay home for 2 weeks. But as this continues to go on for months and months, if every time someone has an exposure or has even a possible exposure, we tell them to stay home for 2 weeks, we're not going to be able to run our centers. And luckily for us, here in New York, we're kind of over the hump now. We somehow made it to the other side. And so there are actually very few people now becoming symptomatic and that have possible exposures. But I'd be curious to hear what's going on for those of you who are a little bit in a different place on the curve than we are.
I think, here in Atlanta, if somebody is, if any of the staff is in exposure, we're definitely telling them to stay for 2 weeks. In the meantime, get the COVID testing. We are pretty lucky at Emory that we have a lot of the PRN technologists. So if there are people that are out, we do get the PRN people to come and work for our center. So we haven't had an issue like that where we don't have enough staff to do the patient.
that's definitely a concern of mine because at our breast center in the Kansas City area, if someone goes down, we have PRNers. But so a lot of my rural sites where you might have one mammo tech at the site or two, one working full time, one working part time, whatever. If one of them goes down or both, I mean, there goes your screening program, right? And those are the areas that are most vulnerable. So I think about that a lot. And particularly, in Missouri, as Meredith may know, like we are not flattening the curve like, other areas are by any stretch. So we're still kind of in that waiting pattern of where is this going to go. So that's definitely, in the back of our minds is, if particularly at my rural facilities, I mean, if someone is out, there goes 2 weeks of doing mammograms, getting women in who potentially would need to get in to get screened, particularly those with, breast cancer. So,
Any of you thought of doing the kinds of things that they're doing in businesses where they have teams of people that work together so that one team kind of stays clean if the other team maybe has an exposure? Is that something that anybody's tried?
We're doing that for our biopsy teams. So we have stereotactic biopsy teams. We try to keep those techs together with the doctor, the physician that we're working with. So we've done that for our biopsy teams.
Yeah, that seems like a good approach. I mean, although honestly, what we found once we started getting antibody testing work is that none of us were positive, and that the few people that actually, even in New York, where everybody feels like there was so much virus a couple of months ago, the people at work that became positive actually got it in the community. I'm not aware of anybody in breast imaging who exposed to COVID and got sick from another person at work or from one of our patients.
Well, I think that's something that's important for us to recognize and for our patients to recognize too. Really, our interactions with our patients, at least on the breast imaging side, is not putting us at the highest risk for exposure. It's honestly our interactions with other healthcare workers. It's perhaps not wearing a mask when you're having a conversation with another physician, when really we should be wearing it all the time. It's those when we're in those small shared spaces, maybe going over a case with another clinician, maybe getting help with something. That's where we have to really keep our guard up and be protective of our masking. So I think we're doing great with the patients. I think we have to, as healthcare providers, make sure that we're taking care of ourselves and taking care of each other.
I agree. All right, so let's talk a little bit about what it feels like to walk into all of your offices now, what the registration and waiting room feels like now, and the kinds of things that you're doing to promote social distancing in your offices. Whoever wants to kick that off.
All right. So for us, just in general, so our breast imaging appointments are spread out throughout the day. So mammograms for us is every 30 minutes instead of the 20 minutes. Also in the waiting room, we've removed the chairs, I shouldn't say remove it, but like we spread the chairs. And so all the patients are about, more than 6 feet away from each other. And when they coming and checking in, we usually have the hand sanitizer right there, and we have a sign saying in the computer, please use the sanitizer before and after. So as far as the waiting room, usually like either the front desk personnel or the techs in between has come and clean the doorknobs, the light switches, not constant, I would say at least multiple times like throughout the day. So the patients, as Nina said, patients wants to see it too, that, that we are taking safety measures, not just that we're saying it, but actually seeing with their own eyes that we are doing safe measures.
Are any of you doing things like having patients wait in their cars or calling when they get there? Is that happening in any of your offices?
Go ahead. So some of our facilities, we are doing it. It depends upon how far away is it in the hospital versus closer to the parking garage. So some of the facilities, we are actually having them, the screening patients, having them stay in the car, and then we were texting them to come in.
Is anybody else doing anything like that?
We're doing the same. And then we're also, if we have a quite a robust geriatric population, they often need somebody to drive them there, perhaps escort them in. So even if you are getting a ride there and you need help being escorted into our facility, then we're asking that caregiver to go back to their car. We're going to call them when their family member or friend is ready, and they can come back to the door to get them at that point. We did something really interesting just because one of our concerns in our waiting room was cross-contamination. You know, if one patient sits here and then another patient sits there, another patient sits there, we tried to look at contact tracing and if we'd be able to ferret that out. We went to a number system, which is when our patients check in, they're given a number that both defines the seat where they're going to sit as they wait and also the room that they're going to go to, so that we were able to, in some ways, trace our patients, contain their space. And then we figured our waiting rooms that they enter in one side, exit the other side, so they're not crossing paths with other patients. So we've really just tried to augment our workflow to decrease the patient cross exposure as much as possible.
We have a similar entrance and exit to the patient waiting room. We've also removed a lot of chairs, and they've actually reupholstered the chairs so that they can be wiped down. So anytime a patient sits down, when the technologist takes them to go to get their mammogram, they place a sign on there to please wait until this is wiped down, and then they take them back, and then somebody comes back to down the chair. So we've changed, some of our furniture so that it can be, cleaned and sterilized. And patients, I think Nina, you'd mentioned before, is making sure patients feel comfortable, and Jean, you mentioned it too. And I think that that's really important for them to see our technologists actively cleaning everywhere. And we're getting some patient surveys that are saying that they are grateful. They feel more comfortable seeing the cleaning process and seeing how.
Yeah, we have found in our place that signs that say clean are very effective. If the clipboard that you're going to hand the patient has been cleaned, and even if they didn't see you clean it, if they see that it comes out of the place where the clean clipboards are, that the pen comes out of a place where the clean pens are. But then for some people, that's still not going to be enough. And so I think having hand sanitizer around everywhere, having wipes around everywhere, we're actually handing all of our patients their own wipes. So if there's something that we didn't clean to their satisfaction, in their own little package, they have a wipe, clean down armrests or anything that they don't feel comfortable being around. It's like I've said before, but it's one thing to be clean. It's another thing to make patients feel safe. And those are really like two different things. And it's a bigger battle, I think, to make people feel that things are clean than to actually do the cleaning. So we've been doing a lot of optional things, a lot of signs. And I think it's really interesting. A lot of you have talked about washing your hands both on the way in and on the way out. Our health system actually has it's a health system-wide initiative that they're calling CHOW, which is clean in and out. And basically that's now the thing. Like you clean on your way into the office and on the way out, clean on your way into the exam room and on your way out of the exam room. And I think not only is the patient washing their hands on the way in and out, but they know that if they did it, that every other patient washed their hands on the way in and the way out. And I also think that gives them confidence that this is going on all day long.
I love that you're using the signage, which really never struck me before, but we put up so much signage, right? The patients need to see that what they're doing and what they're taking is clean. That's huge. Yeah. That's an easy fix that can just go that much more. I find for our patients,
clean is not
for most of
the opposite of clean is not dirty. The opposite of clean is occupied or waiting to be cleaned, but not.
Oh, that's a great idea.
So the signs on our exam room doors either say clean or they say occupied exam in progress. They don't say dirty because, that gives people a level of anxiety that they don't need. And the truth of the matter is when the room's not occupied, it's clean. And so that's kind of the strategy we've taken with the exam room signage.
Well, one thing that's really struck us is that as opposed to, I'm not sure what everybody is doing currently in their community, what their risk tolerance is to go to the grocery store or to get gas. But those are activities that people are doing, if not daily, then weekly or maybe monthly. But screening mammograms is an annual process. So we really thought we needed to teach our patients how to do this. They haven't had the experience of going through this. It's not going to be the same as it was last year. And so we're focusing a lot on those phone calls and education when they come in about this is going to look different and this is why we want to help you feel safer. So I I feel like we probably sound like we're on repeat, but we're saying it constantly over to the patients. We're going to bring you through here differently. This is our new workflow. We hope that it helps you feel more comfortable. We're really doing everything we can.
What about changing rooms? Are you all still having patients? I don't know if you were having patients change in changing rooms, but is changing rooms still something that you're doing? Do you have lockers that patients are leaving their belongings in? How are you doing that in a way that both promotes social distancing and makes patients feel safe and clean about the experience?
We've eliminated our changing room. Patients are changing in their exam room. If and when we move from one exam room to the other, from mammo to ultrasound, or from mammo to stereotactic room, their stuff comes with them. It's in a bag. Only they handle their bag. It's not for anybody else to handle. But we're just trying to keep them and their possessions all together. So our changing room is not being utilized.
Dr. Patel or Dr. Patel, either one of you, is that what you're doing as well? You having
We
patients?
still are using our changing rooms, but our technologists go, and that's another step that they do, is they wipe down the changing room. And so they close the changing room once something it, and wipe it down. And now patients keep their belongings with them though.
Okay. Yeah, I mean, that's basically what we're doing as well. We're actually changing on the way in, but we're not changing on the way out. So we used to have a changing room and a locker. Now we have a changing room with your own personal bag. You go in, you change, you take the bag comes with you into the mammo room, comes with you into the sonar room. And then typically our patients are getting back dressed again, if not in the mammo room, in the ultrasound room, and then going out the door. So it becomes a one-way cycle to our office, and you're not walking backwards towards the changing room where you might be crossing patients on their way in. So that's kind of how it's been working for us. But I have found that changing rooms, it's sort of like the grocery cart in the supermarket. It's hard to get technologists to be able to clean that room in between every patient unless they're not going to be doing the work of technologists. And, what we've told our patients is we're cleaning those rooms often. But at least in my place, we're not able to, unlike our exam rooms and our equipment, we're not able to clean the changing rooms in between every patient. Are all of you able to make that happen?
For us, all the screening patients, we're having them change in the exam room. So obviously our screening volume is like higher than the diagnostic volume. So majority of the patients are getting changed in the screening room. As far as the diagnostic, between usually the technologists don't have the time to go and clean it. Usually like our front desk personnel, once they check into the computer, they are usually the ones that are going and changing, and cleaning, but pretty much only for diagnostic patients, or some of the patients. Even some of the diagnostic patients don't want to change in the locker. And obviously then we do have them change in the exam room. But it is definitely, I can see if you have 40 diagnostic patients on a given day, or 40 patients to go and clean every patient, after every patient, it's a lot of personnel that needs to do it. So it's definitely a cumbersome thing.
Well, because they are cleaning the exam rooms and cleaning all the equipment in between every patient. So it does become a lot, which one of the reasons why we gave the patient the wipes. If you feel like you're going to be touching a surface that you don't feel that comfortable with, you can give it an extra, wipe yourself, which they have in my supermarket with the shopping carts. If you feel like, they're washing these carts pretty frequently, but if you feel like you want the extra assurance of knowing that the handle's clean, here's a wipe, clean it yourself, and that's been pretty effective, I think, for our patients.
No, I think that's a great idea, giving the wipes to the patient. We don't do that, but I think that is a great idea.
That just in case, especially for people who they just want to know that, that handle was clean, or, whatever it is, that's what we're trying to do.
I found it particularly interesting because we'll see the extremes here. And I don't know if you all are experiencing this. I'll have some patients who, when I walk into the room for a biopsy and, I wear the mask with the shield and the gown and they make fun of me. They're like, wow, you're really going above and beyond, But then there's some patients who you can't do enough for. So I found this incredibly interesting that some patients are hyper vigilant about all the safety measures, as they should be, and cleanliness measures. And then we have some patients who are just thinking that it's like overkill what I'm wearing in the room. So it's really interesting.
Where, Amy, you and I are practice in the same area of the nation, so we're having a very similar experience. What I just try to do, and this is why I find having these discussions with you guys so helpful, because here we're all doing great things, but to be able to share, great ideas from one to another, it's invaluable. I just am trying to be as consistent as possible. That I'm always going to wear this in every single room. Sometimes patients say stuff, sometimes they don't. I can benefit from being able to say our hospital requires this. That's my blanket statement. And
yeah, but I also think that's a good and prudent thing to do, because in case one of your patients does turn out to be positive, you want to know that every single patient that you saw to do a procedure, for example, you had your mask on and you had your eye gear on, so that you know whether or not you've had an exposure to that patient. If you're ever not in your normal routine, then you're not going to be able to say for sure whether or not you were protected during that encounter. So I think it makes sense, whether people think it's overkill or not. I've got, for every procedure, I've got my N95 with my surgical mask over my reading glasses and my goggles over my reading glasses, basically.
Yeah, we have a no mask, no service policy, so they're not actually allowed inside if they don't wear a mask, and we provide a mask. Does everybody else have a no mask, no service policy, or? Okay.
What do you do with gloves? People come in wearing gloves.
You mean mammography technologists?
No, I actually meant if a patient comes in wearing their own gloves from the street, like rubber gloves. You don't.
I don't know.
Oh,
I haven't really had that.
nobody else runs into that except for me.
No, we had it too. I kind of feel like, it's like if you don't know how to wear the gloves, they touch everywhere, and it's pretty much like your dirty hands for me. They kind of feel they're protecting themselves, but if it's coming from the street and touching every other doorknobs through the hospital, through the elevators, I feel like it is definitely not a safe thing for the patient. But I think it's in their head that they're doing something extraordinary to protect them, because they're not changing gloves like we do, or like techs do. It's just they're just having it probably for the whole day. Who knows?
Well, when they come to my office, they're not going to wear it for the whole day, because we make them take them off, and then if they want a new pair, we'll give them a new pair later. But we want everyone to wash their hands when they come in, and although some people do try to put Purell on the gloves, you really can't wash your hands with the gloves on. So we take the gloves, everybody washes their hands, and if you want a new pair of gloves, you can have a new pair of gloves with our compliments on the way out to wear for the rest of the day. Because I agree, those gloves, who knows where those gloves have been, and or how long they've been wearing them. So, yeah. But we do run into that frequently. Although I think less now. I think in the beginning there was a lot of glove wearing. I think people have come to realize that hand washing is much more effective than glove wearing in terms of stopping the spread of this. So we're not seeing it as much now in July as we were, in March or April. What about your equipment in your rooms? Are you doing anything different? Obviously, there's a lot of requirements in terms of breast imaging, cleaning that were there prior to COVID. Is there anything that you're doing differently about cleaning your rooms? Or I mentioned we're putting signs on the doors, or anything going on in your exam rooms differently now than there was before?
We always just tell the patients that we have enhanced cleaning procedures. So obviously, I don't know whether patients know that we wipe down the mammography machine in the process. But, also now we're wiping down the doorknobs, the light switch, and the computer the technologists use, which is something that we didn't actually do before. We just did the mammography. And then closing the door. So some of these wipes require like a 5-minute, time period for it to dry in order for it to, to be a sterile surface. So, closing the door for as long as it needs to dry before we use it again. So that's a little bit different too for us.
Yeah, I mean, we're even like, as I'm sure many of you are, cleaning the pens, in between each patient if we need to consent them, and that just goes to saying too, what we've been discussing today. I think that so much credit needs to go to our technologists. I mean, my technologists are tired. We are tired, but we are trying to, you know, uphold the highest protocol, the highest safety measures we can every day, day in and day out. But those technologists are so crucial to the safety and cleanliness of our breast centers. So I just have to give a shout out to them because I know everyone's tired, but they've just been doing such an exemplary job with just heightened cleaning measures for patients.
They are truly on the front lines all day long and basically hugging dozens of patients a day while they're positioning them for these mammograms. And I can't say enough for, especially back in the beginning when we really didn't understand a lot about how this virus spreads or works. For our, for our sickest patients, for the people who had palpable lumps and things that need to be evaluated right away or needed biopsies, our technologists never shied away from being there to support us during that stuff. And this is a team. Like, it's moments like this that you realize how you were talking about the breast, your navigator, your nurse navigator, like these are the moments that you realize how every single person on your team, from the front desk, making them feel confident when they walk in the door, all the way through, is so critical.
I think it's very important as we as radiology and breast imaging leaders in our various communities, we have to advocate for our technologists because, Nina, as you pointed out, they are literally hugging every patient that they examine. They're not, it's a different role than maybe a CT tech, an X-ray tech, or another technologist. They have a very unique relationship with their patients. So we have to advocate for our technologists, for our nurse navigators, for going above and beyond, our front desk and clerical staff who are checking the patients in, registering them, our other radiologists in our group, because everybody's comfort level is in a different place. And then we have to make sure we take care of ourselves. And so it goes back to why I try to do the same routine every day, because if I don't do that, I'm going to forget to do something. So I'm always trying to remind our radiology staff, let's make sure you're masking up, gloving up, glassing up for every single encounter if you can. So yeah, it's a team.
Yeah. Are your trainees still doing all your biopsies and procedures as they were before? Did you have trainees around you at the height of this thing? Were any of them redeployed?
We had our fellows with us during the time of the COVID, but none of the residents, we didn't have any of the residents come in for any of the procedures, but our fellows were with us during this time. They were working just as the attendings were.
Yeah, ours were as well.
Same.
Is there anything that all of you have done in terms of workflow in your offices to, in response to this situation? Reading screening mammography online, perhaps, or more same-day biopsies, or anything else about the way that you are handling your workflow as a result of this?
One thing that we changed, which wasn't apparent to me that we were doing until we weren't doing it, is our techs would go in the room, perform the diagnostic exam on the patient, come back to our office and talk to us about it. And same for our breast ultrasound technologists. Go do their exam, come back and talk to us about it. And we, early on, especially when we didn't know how things would play out, we put a hard stop to that. So we designated 2 specific telephones that the technologists use to call us to talk about the case with us, and they wipe it down every time they use it on both the mammo and ultrasound side. And then we really have a lot of conversations about, is this a patient that I need to come in and talk with? Or is this a patient that you can give results to? Or is this a patient that needs to consult with our nurse navigator? Or can I talk to them on the phone? So we really have tried to minimize the cross traffic in our imaging center, which, my favorite part of the whole job is to talk to the patients, but we do have to be as practical about it as we can.
And honestly, one of my favorite parts of the job was talking to the technologists. So, we've adjusted our workflow a lot as well. Our workflow used to be, as you say, a lot of mammo and techs walking back and talking to us. And we've eliminated most of that. We actually switched to an internal chatting situation, which both stopped them having to be in the reading room with us, but also allowed us to get them all out of the common work area that they were sitting in. So because our chat is visible on any computer, they could actually, in between patients, be in an exam room and still be able to be on the chat. And so we actually, on any given day, we have 2 diagnostic readers and each one has their own chat. And it's them and all the mammographers and all the ultrasound people, all the ultrasonographers for the day are all on that doctor's chat. And every time there's a new patient or you want to tell them to get extra images or whatever, you're communicating with the whole group of them, and any one of them can write you back at any moment. But I do kind of miss seeing them in the room. Like every once in a while you have to go out and like just find them and just give them a virtual hug, because it is a little, that was what we did. You know, we not only did we talk to patients a lot, we also interacted with our staff a lot more than we do now, or at least I did.
Absolutely.
Yeah, I do miss them. The other thing that we've been doing is we try to take out the waiting times in between things. So like we do a lot of screening ultrasound where half our patients, almost all of our dental patients have a screening ultrasound on the day of their mammogram. And there used to be a little bit of a wait in between that. You know, the patient was done with mammography and then they would hand the chart off to someone in ultrasound, and the ultrasound tech would get the room ready and then go find the patient in the waiting area. We've now created little teams of a mammotech and a sonotech. So when the mammotech brings the patient in for their screening mammogram, they identify an ultrasound tech and they say, you know, I'm bringing this patient now. And then the sonotech goes and gets the ultrasound room ready so that we can bring the bring that patient right from mammography into ultrasound without having to go back to an internal waiting area. Little things like that. But is anybody doing things like doing more online reading of screening or doing more same-day biopsies or anything like that? Is that something that any of you have put in?
Go ahead.
We're doing, there's no online screening. We are actually going into daily into work and screening from the, you know, from our places. But as far as during the time of the COVID, we had a couple of the breast surgeons that wanted, if there was a palpable mass, like they wanted to do the biopsy, but we told them, you know, during the time of COVID that we want to do the same day biopsies. So we did do that because the volume obviously wasn't like that high. But now we're back to, since the volume is back to normal, we're back to our old schedule.
Yeah, we are as well.
Things like same day biopsy, I think it's very variable per state, because like, for example, like where I practice in Missouri, and I don't know if Meredith experiences this too, although I was a fellow at WashU at one time, so I should know this question, but they are in St. Louis. But like for us, you know, it takes time for prior authorization, and so oftentimes we can't get them in the same day, even though we really want to get them in. So we have done things just like you have mentioned, Nina, where we are not having the patient go back when they need to go to ultrasound. The techs are communicating, we get them in the room, get them scanned, get them out, and we're, you know, we're doing these measures. We're also not, we were allowing walk-ins and stat reads. We're not doing any of that right now because we really need to be able to structure our appointment times, make sure that there aren't, you know, we're employing those strict social distancing measures. So, but things like, you know, same day biopsy for us is actually very difficult with our payer mix.
And we have, and I'm on the western side of St. Louis. So as you know, when you talk about the St. Charles, St. Peter's, and Fallon communities, et cetera, people are driving a ways to get to the hospital, right? Anywhere from 1 to 3 hours for their appointment. So we've always strove for same day biopsies. If we can at all achieve it, we try to do them. But now we're getting orders and pre-authorization for it and with the possibility of doing a biopsy. We're even counseling patients, especially those coming in with a palpable lump, et cetera, that there's a strong likelihood we're going to try to biopsy you today. You need to be ready for that. And I think they both appreciate the timing of that, but also just there's just a sense of like, okay, I'm coming in, I'm going to get everything done all at once. It feels more efficient to them. So it's definitely meant longer hours as for the radiologist to try to incorporate all of that and still keep everything as clean and as safe as possible. But we're doing the best we can.
Would any of you want to talk about how you're communicating with your patients and telling them what they can expect in your office? Is it something that you're sending them by mail? Is it a phone call? Is it an email? Is it a text message? Is it something on your website? What have you found? Or is it things hanging on the wall? What have you found or a combination of all of that? What have you found to be the most effective in terms of letting patients know what you're doing?
We're doing a combination of all of those things. So, you know, there's an automated phone call before their appointment. Also, the technologist calls them before the appointment. We have the OSU, the Ohio State website has, you know, information on there about the measures we're doing, and that we're still open and available for any needs that they have. They've done commercials too. So trying to reach patients in any different way. I think though that person-to-person phone call where you can really answer any questions with the technology navigators is sort of the one that patients seem to appreciate the most, at least based on our.
Yeah, we're doing a combination as well. I mean, even the hospital has, Liberty Hospital, where I practice, has the Ready for You campaign, where we're talking about what the safety measures we're employing. We're showing videos on social media and images, and as well as sending out letters, talking to patients, our technologists, our nurse navigators. I really think that what we're seeing across this country is just this all hands on deck approach to really tell our communities that we are employing the safest practices that we can during this time.
I agree. All right, we have just a couple minutes left before we hit 7 o'clock. So I wanted to give each of you an opportunity to tell me, is there one thing that you would like women to know about having breast imaging at this time? I just want to give you each an opportunity to just say whatever you'd like women to hear.
I think that it's safe. We are open. We want to make sure that patients are not skipping an exam. It's to delay it for a couple of weeks, for a couple of months, or whatever your local government thinks. If you are in shutdown or whatever. But we just don't want patients to just skip entirely 2020. I know a lot of us want to skip 2020, but we don't want them to skip 2020 in terms of their imaging.
Okay.
Yeah, we're doing the same thing as Dr. Patel said, that, we are here for you. And as Dr. Vinkoff said before, it's just a pause, but not a stop. And so we definitely don't want anybody to skip 2020. And the few months delay for most breast cancers, it's fine, but it's still, now it's open, and almost all of the breast imaging centers are opening it safely with safety measures. So we are here for you. And that is the message that I wanted to let every woman know.
Dr. Byers, Dr. Patel.
Yeah, I think that just echoing their sentiments that, we are ready and this is safe for patients. I also think that, although it is more time intensive, we have patients who are very, wary of this, and perhaps our front staff, our office people can't, get through to them, or a nurse navigator. I think that as breast imagers, we should be available to talk to these patients, to assuage patient fears. So yes, it might take a little bit more time on our part, but it could most certainly save a life, especially if somebody has a palpable and ends up being a really horrific breast cancer they've been delaying for months. So I think that now more than ever, we need to be more patient facing and be willing to speak with patients to calm them and to assuage fears.
I totally agree with all of that. I would also say, as you all have said, this was a pause, but not a hard stop. If you're wanting and worried about getting your mammogram, if you miss the chance, now is the time to call and get that appointment set up. We're coming up with new and creative ways to make sure that all of our patients can be treated both safely and efficiently. But we'd love to get you on our schedule. I'd say the same thing to our practitioners and our healthcare providers. If you have a question about your patient, this is a great time to call, and let's talk about what their risk factors are and what we need to do for them. We want to keep that communication going. And I really want patients to know, if you are sick, if you're not feeling well, if you can answer yes to one of the questions we ask you, we will get you rescheduled. We will make sure that you've got an appointment when you need it, but we most want to make sure that your health is a priority to you, like it's a priority to us. So we will work with you to make that happen.
And I just want to add before we finish up that, we've talked a lot about the things that we're doing, but if there's anybody listening to this who still feels uncomfortable, who wants to know specifically what their breast imaging center, please call. Like, please don't, out of fear or concern, not ask the questions, because I think if you ask the questions, you're going to hear, in addition to just the 5 of us, that this is the kind of thing that's going on at breast centers across the country. We are all doing similar things, and we are all providing this care in a safe and clean way. So please ask the questions. And I think once you do, you're going to feel confident about coming back. Annual mammography saves lives, and it doesn't just save lives, it allows us to find breast cancers when they're small and easier to treat. So don't skip, just a pause, don't stop. It's just a minute before 7. So I just really wanted to say thank you. I know it was a lot of us on this call today, but I learned a lot. I took a bunch of little notes in my notebook here of things that you all were saying. I'm sure lots of other people did today too. And thank you all so much for participating. Next week, this chat will be back. I wish I could tell you I knew off the top of my head what next week's topic was, but I'm sure it will be posted on our various different social media outlets. And thanks, everybody.
Thank you.
Thank you.
All right. Take care, everybody.
Bye, everyone.
Bye.